So there are some significant special considerations, and pregnant patients are one of them. And any female of childbearing age, which is puberty to late 40s, early 50s, we should always ask, is there any potential for them to be pregnant? Because there are medications that we may give or that they may be prescribed that are absolutely detrimental to a fetus and or will cause complications with pregnancy. So make sure that any time that we're dealing with the females in regards to a patient, that is a question that is being asked. And then you always want to follow that up with a double question. And if you ask them, are you pregnant? And they say no, you can ask them, how do you know that you are not pregnant, or when was the last time you had a menstruation? Because this is something, again, that you want to make sure that you know, because you don't want to be the one that potentiates harm on a fetus. Prescription and over-the-counter drugs can harm a fetus as well. And this is the due diligence of a patient who needs to understand what they're putting into their body when they are pregnant. And the changes in a pregnant woman's body will oftentimes affect the way the drugs are processed, and then if it can cross the placental barrier as well. The FDA has a scale that indicates the dangers posed during pregnancy, and we're going to get into that here, which is category A. There is no documented risk. B, have shown that animals have not shown a risk, or adequate human studies have not been done. And then class C says that there's an effect demonstrated in the animal studies, but because of that, there was not a study conducted in humans, right? That's an unethical study. And then class D is that we have observed, or the medical community has observed, that this particular medication has caused fetus damage or harm, and that drug administration often will outweigh the risk in those circumstances. And then anything that's a category X should absolutely not be administered to women who are potentially pregnant. And this is something, again, that can clearly be shown to cause harm to either mother or unborn baby. So because many of the drugs have really unknown effects during pregnancy, you really want to try to stay away from administering drugs, if at all possible, to a pregnant patient. Now, that doesn't mean withhold life-threatening or medications for life-threatening illnesses or injuries, and certainly there has to be some kind of discussion if you're going to try to mitigate pain. If mother has a significant trauma, you may make them more comfortable with a small dose of an opiate, but it should be a conversation that's had between you and the patient and your medical control before you get into that situation. So make sure that you're able to evaluate in the field, and then always call a doctor if you're in doubt. So when we're talking about children versus adults, medications can have a different effect. Physiologically, small children are put together the same way as an adult, but their way of metabolizing things is going to be delayed because they just don't have the same size organs, and the doses are going to have to be really considered. They may have to have a much higher dose because of their way of metabolizing it doesn't make it effective, or they may need more, or they may not need nearly as much, right? Often you guys will see that you'll see most of your drug doses are cut in half as a general guideline in your pharmacy study guide. And then there are certain drugs that absolutely mimic an adult dose. If it's a weight-based drug, it's still going to be, we'll say, like in the case of fentanyl, it will end up being the 1 microgram per kilogram, just like an adult would. But again, make sure that you understand the difference between those drugs and how they're going to be dosed, because we never want to overdose or underdose a pediatric patient. In our elderly population, there are changes in pharmacokinetics compared to the young children and normal healthy adults. And that's really, again, that how are we going to metabolize and absorb or eliminate that drug? What is the half-life going to be? And so in certain cases, if their organ function is lowered because of just strictly due to age, or maybe perhaps other medications or other underlying factors, you may give them a dose of medication and think that it would be appropriate to give them another dose of medication, but because they've not properly metabolized that like a normal, younger, healthy human, they are going to end up with an overdose situation. They can be taking so many different medications that we really truly can't understand all of the effects that some of these drugs can have with one another. So you want to tread carefully, right? Because this can cause those interactions, and we may end up ultimately causing an altered mental status. And once we kind of get there, we're kind of stuck. And so we really want to, again, tread lightly when you're in those situations. In regards to scope of practice, as the slide says, you are legally, morally, and ethically responsible for the drug that you administer. And in the same case, you are also legally, morally, and ethically responsible for any drug that you cross-check. The new standard of care in EMS is called medication cross-check, and that means that you should be able to do the medication math, and you should understand that that is the correct drug for the correct patient at the correct time. So make sure that you keep references handy for you to look up, and be that a formulary or a protocol book. That is something that you absolutely want to make sure, and make sure that you stay sharp on your medication math. You want to know absolutely without a doubt that somebody is not going to give the wrong medication, or quite literally the wrong dose of medication. And it's always better to say stop and have that conversation before you administer the drug than to question whether you did the right thing after the drug was administered, because unfortunately, once we give something, we're unable to retrieve it. So the methods of drug classification are based on the effect that the drug will have. And when we're talking about that, this is your class of drug, and you guys are going to see this on your medication quizzes almost always. And we're looking for what body system it's going to have a targeted effect on, and then what is the class of the agent that is going to create how that drug works, right? And so when we look at something, again, like say Tylenol, we're going to say it's an antipyretic analgesic, and it's also an NSAID. So those are three kind of classes or classifications of that particular drug, because it's doing certain things to the body. And because we understand its mechanism of action, we can actually determine the class of the agent. Now, if we're getting into the nervous system classifications, this is the body's principal control system. And again, this is the central nervous system against the peripheral nervous system. And then the autonomic nervous system, which is your involuntary, right? This is the automated control centers in the body. So that is divided in sympathetic and parasympathetic, and the sympathetic nervous system is that fight or flight, and this is where we increase the heart rate, and breathing increases, the pupils dilate, right, that whole process. And then we go into parasympathetic, and this is that rest and relaxation, or feed and breed, and this is where the body systems tend to slow down, because the body is now working on specifically creating nutrition out of digesting food and regulating hormones. Now, when we're looking at that, if you're looking at a drug that is a sympathomimetic, that affects the sympathetic nervous system. It's in effect doing the exact same thing. So in this particular case, we're going to call that epi, which is a derivative of adrenaline. And what we're doing there is mimicking the body's production of adrenaline with an exogenous medication, which is our epi. And if we have an antagonist, it's going to counteract that particular action. And then an agonist is going to bind and cause that action, right? And so when we're looking at something like beta blockers, right, they prevent the beta effect. And one of the drugs that you have besides epi that have a beta response is albuterol. So if you have an elderly patient who's on a beta blocker, and then you give albuterol to that particular patient, you may not see the intended result that you're looking for, because the drug has a stronger affinity for those receptor sites in the body than the particular drug that you're giving them to treat. And this is another one of those things that we should be very aware of the drugs that our patients are taking, and becoming familiar with their medications, so that we understand, are we going to get to the end result, or do we need a much higher dose or an MSEP consult to kind of figure out how to circumvent these issues? Parasympathomimetics are agonists, and they really replicate the parasympathetic nervous system, right? And so if they are antagonists, it's going to block. And so with excessive cholinergics, the patient may exhibit the acronym SLUDGE, which is often associated with organophosphate poisoning. So I'm going to have you guys look SLUDGE in your toxidromes in your textbook and see if you can understand why those particular things are going to pop up with excessive cholinergics. Analgesics are medications that relieve pain, and then if we're looking at opioid agonists, those are a common class of drugs used for analgesia, and that's going to be morphine, Dilaudid, and fentanyl. In our particular local system, morphine is no longer distributed to any of the 3 large services, and Dilaudid is not routinely used in the EMS setting, but fentanyl is now probably the most in vogue drug given for pain management. And then we have non-opioid agonists. Many of them are over-the-counter, and that's the salicylates, and that's your aspirin, Tylenols, and para-aminophenols. Think about your aspirin, your Tylenol, and your ibuprofens as pain relievers and non-steroidal anti-inflammatories. So if you have an opioid antagonist, that reverses the effects of an opioid drug. And in this case, we're talking about Narcan or naloxone, and the receptors in the body have a much higher affinity for Narcan or naloxone, right? This is the trade name versus the generic name in regards to the opioid drug. So one of the things that I want to make sure everybody understands is that if you are giving a opioid class medication and you slightly overdose and you cause respiratory depression and maybe some altered mentation, think very carefully about how you're going to treat that patient. And if it's something that's significant and you know that they're so obtunded that you have to give Narcan, I want everybody to remember that if you give Narcan, the effect of opioids is completely diminished, if not destroyed, for quite a bit longer than the half-life is of the particular drug you were trying to give that pain control for. So not only in effect did you take away their pain management, there is no way to treat it effectively until the naloxone actually wears off. Anti-anxiety, sedatives, and hypnotic drugs. These are your benzos, barbiturates, and then non-barbiturate hypnotics. This is quite often Valium and Versed, and this is not in the AEMT scope of practice in most states. It may be a special skill in some secluded areas that show a benefit and can meet the training standards for that, but that's not something you're going to see standard across the United States. This is a paramedic level drug, but you should be very familiar with the names and understand what people are using them for. Anticonvulsants are for seizures, right? So that's anti and then convulsant being the seizure portion of that. And the exact mechanism is really unclear. There seems to be some different things where they are sitting in the nervous system and perhaps unexciting the nervous system pathways. And some of those are benzos, barbiturates, hydantoins, and then valproic acids. We're going to get into stimulants, which is a common group of the CNS agent, and that's obviously caffeine or cocaine, and then they tend to increase wakefulness. This can also be ephedra or ephedrine, and then the side effects of this, because they are sympathomimetic in nature, is some tachycardia and hypertension, right? Because we're increasing the sympathetic nervous system. And if used in high doses or in amounts that are at not a very safe level, you can induce seizures, psychosis, irritability, tremors, and headache. Then when we look at depressants, this is a slowing, and they are parasympathetic kind of mimics, and that's your Xanax, your Ambien, and most often they're used to treat anxiety, muscle tension, pain, insomnia, stress, panic attacks, and seizures. Psychotherapeutic drugs block dopamine receptors in the brain. They're primarily used to treat schizophrenia and depression, and they have some side effects like extrapyramidal symptoms, orthostatic hypotension, which means that they would stand up and become hypotensive, and they can be kind of sedating. Drugs affecting the cardiovascular system, These medications are basically used to control blood pressure and heart rate, and this is certain drugs that have effects on the chronotropic part of the heart system, which affects the rate, the inotropic, which affects the strength, and the dromotropic, which is the speed of the muscle contraction. So just try to remember those three terms and remember where they're at. Cardiac glycosides block ionic pumps in the heart cell membranes. There's a bunch of side effects. And then we have the antiarrhythmic medications, which are to prevent cardiac rhythm disorders. You potentially have the ability to have access to something like lidocaine, which is in its own right used as a antiarrhythmic, or I should say antidysrhythmic drug. So although we use this as a numbing agent in the IO, you have to make sure that you actually understand that there is potential harm if you overdose and give that drug to where it would have an unintended consequence on the cardiovascular system. So these drugs are classified into groups according to the fundamental mode of heart or action on the heart. There's antihypertensive medications, and there are a lot of people on that have hypertension or pre-hypertension who are on medication. And the goal is to keep your blood pressure in a low, safe limit. And every couple of years, that limit seems to move lower and lower. And really, we're looking to not create that forever increasing resistance on the aortic system. Right? We don't want the heart to grow in size because it's having to continuously pump against more and more afterload. So these drugs have different ways of manipulating the body so that the pressure reduces itself, and then it reduces that stress on the heart. So some of those drugs are diuretics, vasodilators, sympathetic blocking agents, ACE inhibitors, anticoagulants, fibrolytics, and blood components. So while not all of these are doing anything to actual blood pressure, they do have something to do with blood or the system in which blood is moved throughout the body, being the heart and the vascular system. So drugs affecting the respiratory system, oxygen is obviously the most commonly used drug in the pre-hospital setting, and the use of over-the-counter decongestants is common in many patients, and that could be anything from synephrine or the like to antihistamines for hay fever. And then you should probably know what your patient is taking. One of the key things to note in oxygen is that no longer do we just give oxygen because it's free or it may make the patient feel better. We're not really looking for an emotional cure out of oxygen, and if they have a normal to a higher oxygen saturation level, we can actually induce free radicals from the or I should say excess oxygenation in the bloodstream, which can actually cause more damage. So in this particular slide, severe respiratory emergencies often arise from narrowing of any portion of the respiratory tract, and that in effect really is our anaphylaxis, our asthmatics, and then if we have any of the chronic or acute bronchitis, these are all conditions where those particular airway tracts are narrowed and may have mucus in the actual tract, which is preventing gas exchange at the pulmonary membranes. So we use sympathomimetic medications to basically smooth muscle, relax, and expand the respiratory tract. Xanthines are the second line in respiratory emergencies.